So Jackie, thank you very much for coming.
Great, thanks, Mary. Great, thank you. I think I'm on now, right? My mic, perfect. Thank you so much for having me. It's really a privilege and pleasure to be here and to meet friends as well. So it's thank you for that honor. So I've been involved with this field in LAA closure for about a decade, actually. It's been a really exciting ride over the past decade. And these are some of my disclosures. I've been very fortunate to have been able to be involved in a few research projects and papers in this area. And also in the past decade, the opportunity to proctor in many different centers in North America and in several countries as well. So it's a nice experience, and I got to meet with so many different interventionalists and electrophysiologists around the globe. So it's been very exciting. So a few disclosures: having research grants from a few grant funding agencies and device companies, and being a proctor and consultant for Boston Scientific and Abbott Vascular and other device companies. So before I came here, I was very excited and very pleased with my mode of transportation, my bike, until I was driven around by Mario yesterday. And then I'll go back over there. And it's like, I'm clearly in the wrong job, in the wrong city. I gotta find a new job. Anyhow, so I've been asked to give an overview on an update on surgical and transcatheter therapy. So I'll give you an overview about AFib and stroke prevention, and start off by talking about some of the surgical literature, and then the percutaneous data, and then some future directions on new devices and new directions for this device therapy. So AFib, as most of you know, is the most prevalent adult arrhythmia. It affects 1 to 2% of the general population. And octogenarians, about over 13% of patients are affected with AFib. And this incidence is anticipated to double by 2050. And AFib is actually not benign, as you know. It increases the risk of stroke by about 5-fold and increases mortality by 2-fold. And AF-related stroke is actually higher risk in terms of causing disability as well as mortality compared to other causes of stroke. And therefore, there are very stringent guidelines as to when we should institute oral anticoagulation to prevent stroke. So this is for non-valvular AFib prevention for stroke. The ACC updated guidelines in 2019. Level 1 evidence for recommendation is CHA2DS2-VASc score 2 or greater for men and 3 or greater for women. In Canada, we're a little bit old-fashioned. We call it a CHA2DS2-65 score, where an age over 65 will be an indication as well as all the other indications for stroke preventive therapy. But we know that anticoagulation is very difficult to administer for a lot of patients. And you can see here in the national registry, in the Pinnacle registry in the US, 430,000 outpatients with AFib in the US. Despite meeting the indications for oral anticoagulation, still about 50% of patients are not on OAC. And that is in the era of warfarin. And even in the newer era, where we have the availability of the novel agents, in the Garfield AF updated registry of 40,000 patients, still about 30% of patients who meets the guideline criteria for OAC are still not taking OAC. So what is the reason for that? A lot of the background complications with novel agents still exist despite being a new agents compared to warfarin. So the annual risk of major bleeding with the new agents is still about 3% per year. And so when you look at discontinuation rate with these new agents, it's still between 20 to 30% in 2 years in these large randomized controlled trials, not just because of major bleeding, but because minor bleeding and even nuisance bleeding and intolerance to these agents. And so if you look at real world discontinuation rates with these new agents, with the bigger trend out to 2 years is about 40%, rivaroxaban about 30%, apixaban about 20%. And even if you prescribe oral anticoagulation, can you guarantee the patients are taking it? So when you look at the adherence data, this is actually really surprising to me. So even with the new agents, adherence is only about 60% with the new agents, marginally better than warfarin, which is 50%, but still. And we know that non-adherence to oral anticoagulation can increase your risk of stroke as well. So these are, I think, very sobering data, which is why there's been a lot of target towards addressing the source of the clot itself, which is eliminating the left atrial appendage as a form of therapy. So the LAA is a remnant of the embryonic left atrium. It's usually a very highly variable anatomy in different individuals, almost like a thumbprint, we say. And it's usually a blind-ended pouch, long, multiple lobes, and usually consists of a lot of trabeculations from pectinate muscles. And it functions as a decompression chamber and storage of ANF. So in the setting of atrial fibrillation, the left atrial appendage undergoes a number of functional and structural changes and inflammatory changes on top of that. So together with the Virchow's triad of events, this leads to thrombus formation in the left atrial appendage. In fact, studies have shown from TEE studies and autopsy series shown that in the setting of non-valvular AFib, when clot forms with AFib, it resides in the left atrial appendage in about 90% of cases, which is why this device therapy is targeted to be removed to prevent stroke. So in fact, the first surgical excision of left atrial appendage closure was about 70 years ago now. And I'll go through some detail about some of those data. In terms of percutaneous therapy, that's really just in the past 18 years. The first procedure was done with a Plato device in 2001. Now this device is no longer available. It was very rapidly replaced by the Watchman device, as well as the MPLATs, or cardiac plug. And over the past decade, there's been a whole slew of new iterations of these devices and other devices in the marketplace as well as epicardial types devices. So I'm going to focus on the endovascular from the percutaneous side after that. So to start off with surgical data, this is taken from one of our textbooks written by Richard Whitlow, who's the PI of the LAOS 3 study. And he gave a really nice summary of all the various techniques that can be done for surgical excision of LAA closure. You can do it by ligation or excision. You can do it by suture, by stapling, or even with devices. So typically you can divide these various approaches into either endocardial approaches or epicardial approaches, and it can be device-enabled or non-device-enabled. And device-enabled can be simply a stapler or with the new tools like the EtriClip closure device. Now, because of such variation in terms of techniques, the success rate is really also very highly variable. As you can see in the literature, success rate ranges from 17% to about 100%. And some of the original data from Cleveland Clinic really raised the concern that if you have incomplete closure, and in their series, they had 2,500 of cases of LA occlusion, of which 137 have post-op TEE. If your success rate is defined on TE as not having a random stump of more than 1 centimeter and no persistent flow into atrial appendage on TEE. So success rate in their series is only about 40%. And patients who have unsuccessful LA closure, there was a higher risk of thrombus formation. About 41% of cases they have clot in the LAA. So that raised the concern that incomplete closure can be worse off than not even closing. There's also other complications related to LA surgical closure. So that includes injury to the circumflex artery because it's the proximity to the left atrial appendage, injury to the left upper pulmonary vein, myocardial tears and bleeding. So there's concern, but despite that, a lot of surgeons, when they're doing open heart surgery, especially with valve surgery, mitral valve, still remove the appendage, even though there might be potential risk, and then the evidence is not quite there yet. There's no randomized trial available as of yet. But very recently, there's a couple of important papers I'll just bring up to your attention that that shows that surgical closure might be beneficial. So this is the 2 JAMA papers. This first one is it's a large series from the STS surgical database. 3,900 patients underwent surgical LA closure, and their follow-up was 2.6 years. When they look at the endpoint of thromboembolism and all-cause mortality, that was actually reduced in the surgical group. So this is a retrospective study, but nevertheless suggestive that doing this device closure can be beneficial. Now, this is another paper also published in JAMA a few months later. And so this is a different retrospective administrative database cohort of patients, 4,400 patients who had surgical LA closure. 1/4 didn't have baseline AFib. They did a propensity match score to another group of patients who did not have LA closure, and patients would follow up for a mean 2.1 years. And what they found to an overall cohort, there was a reduction in stroke and mortality as well, although it appears to be mostly limited to patients with AFib at baseline, as opposed to the non-AFib. But the interaction between LA closure and prior AF was not statistically significant. And also for patients without baseline AFib, doing LA closure increased the subsequent risk of AFib as well. Okay. Now, this is a meta-analysis just published a couple of weeks ago. They looked at 6,800 patients from 10 studies. It didn't include one of the study I showed, the Friedman study, but nevertheless, what they found was when they did this meta-analysis of these 10 papers, there was overall a reduction in terms of ischemic stroke with surgical LA closure, as well as lower risk of mortality. And again, highlighting that probably, even despite the absence of randomized trial data, that surgical closure probably is safe. Now, most of those studies were relatively old and did not include the device-enabled studies. So AtriClip, if you think about what is the largest volume of device that's being implanted, it's not Watchman, it's actually AtriClip. Okay, so there's just been this more than 120,000 of these clips deployed worldwide without randomized controlled trial data. So AtriClip is 510K approved in the US for LA closure. It can be implanted with open heart surgery or thoracoscopically. And so it comes in 4 sizes, 35, 40, 45 to 50. The best data out there is actually this single center retrospective study of 291 patients who were undergoing open heart surgery who was successfully implanted with AtriClip. And the authors reported no procedural complications. They all required TEE intra-op to confirm not having a stump more than 1 centimeter. And patients, majority had AFib to begin with, and 2/3 were discharged in OAC. And at 36-month follow-up, they did not see any device-related complication. And when they looked at the incidence of ischemic stroke that was observed, it was about 90% lower compared to expected rate based upon their CHA2DS2-VASc score. Their CHA2DS2-VASc score is a bit low, it's 2.8. And you see that this is much lower compared to the endovascular LA closure series of patients. And in a meta-analysis that's just published recently as well, that included 11 studies, of which 922 patients had AtriClip that was implanted. 4 studies were done thoracoscopically. The remainder had some version of sternotomy or mini thoracotomy, and success rate was about 98%. And interestingly, these are all retrospective series essentially, but they reported no adverse events. And the stroke rate on follow-up was low at 0.2 to 1.5. But mind you, these series are not adjudicated, right? The endpoints are not adjudicated and not followed by neurologists regularly. So you have to, call into question the validity of some of those summary. But nevertheless, AtriClip implants appears to be safe. The other reviews did show that you can get some complications such as pericardial effusion, even pericarditis. In about 1% of cases, you can get tachyarrhythmia and atelectasis because you still need at least single lung ventilation. And overall, there's still unclear role of the need for oral anticoagulation after implanting an AtriClip, and there's limited outcome data on success rate long-term, and there's no randomized controlled trial. So the largest randomized trial currently that we're waiting for is the LAOS 3. So Richard Whitlock from Hamilton, Canada, is the PI. They finished enrollment of 4,800 patients to date. So they included patients with AFib, undergoing on-pump cardiac surgery, and they randomized the surgical occlusion of LAA versus not. And the mode of closure is at the discretion of the surgeon. So you can use AtriClip, but most did not get AtriClip, according to Richard. And after LA closure, OAC was recommended. So we hope to hear data from this over the next couple of years. So at the meantime, what are the recommendations for surgical closure? So it's class 2B, so it's a weak recommendation. Surgical occlusion for LA may be considered in patients with AFib undergoing cardiac surgery as a component of an overall heart team approach to the management of AFib. And the level of evidence is B, NR, meaning non-randomized trial data. So moving on to percutaneous closure. From this table, we've updated this table. You can see there's a whole slew of devices that are available. Several are CE mark, a few others are in clinical development, even preclinical studies. But the only endovascular device that's approved in the US is the Watchman. So Watchman was first implanted in 2002 and received CE mark in 2005. FDA approval about 10 years later, and Canada approval about 8 months after FDA approval. currently available in more than 80 countries, and more than 100,000 of these devices have been implanted worldwide. So it's done through femoral venous puncture, transeptal puncture, and deployment of the device under usually TEE guidance or ICE guidance into the left atrial appendage. And in animal models, typically at least 30 days to 45 days in dogs are required for complete endothelialization. In humans, it actually might be longer as well, and I'll go through some of that later. So Watchman is the device that has the most clinical trial evidence compared to all the other endovascular devices. The two important randomized trials are PROTECT AF and PREVAIL. These two RCTs, followed by their CAP and CAP2 registries, were done early on in the sort of era of the warfarin, not the NOAC era. And more recently, ACEP2 study was launched about 2 years ago. So now this device therapy has really gone through a lot over the past decade. Procedural success has really improved with increasing experience. Now the technical success rate is about 99%, even despite a lot of these newer real-world registries included majority were new operators in these studies. As well, the complication rate has gone down over time. If you look at the first half of PROTECT, the major complication was up to 10%. Half were due to pericardial tamponade, and the remainder were a lot of ischemic stroke due to air embolization. But techniques have evolved, so we've been much better at prepping the devices to clear the air, and we also use pigtail now to advance the sheath into position to minimize the risk of tamponade and perforation. And you can see in more recent trial data, even if you include vascular complication, the complication rate is only about 3% now. And it's not only in the clinical trial data, but in real world practice, we see this decrease in terms of complications. So when you look at the major complication of tamponade, procedure-related stroke and device embolization is less than 1.5%. In most experienced centers, is only about 1% or lower, and that's the number that I quote my patients. In terms of efficacy, for this device closure, for the two landmark trials, PROTECT and PREVAIL, as I mentioned, these were designed in the warfarin era. And they were included patients who were warfarin eligible, and patients were randomized in a 2-to-1 fashion to Watchman versus warfarin. And after Watchman implantation in both these studies, because it takes time for endothelialization to occur, it's recommended that warfarin is given for 45 days after Watchman together with aspirin. And then after that, warfarin switched to clopidogrel out to 6 months if there is no peri-device leak more than 5 millimeters. And then after 6 months, clopidogrel is stopped, and you just continue on aspirin lifelong in these two series. So the outcomes for these two studies in the meta-analysis, which included 1,100 patients, follow up to 5 years, are as follows. All stroke and systemic embolization essentially is non-inferior comparing Watchman to warfarin, but there was a significant reduction in hemorrhagic stroke by about 80% with Watchman, and reduction in disabling and fatal stroke by about 55%, and reduction in cardiovascular death by about 40%. And even appearance here of all-cause mortality that was lower with Watchman therapy, and about half the incidence of major bleeding that's non-procedure related. In terms of ischemic stroke, there appears to be not quite as low reduction compared to warfarin therapy. And there was some question raised as to, well, does Watchman actually reduce ischemic stroke? So the authors here, Vivek Reddy and David Holmes in the group, they analyzed this data in different ways, but one of the ways to do this was they plotted out the incidence of observed ischemic stroke in all patients who receive Watchman therapy in these studies, so that we PROTECT, AI, PREVAIL, etc. And so the observed rate of ischemic stroke falls in line with patients who were treated with warfarin. So again, as an indication here that, yeah, Watchman actually does reduce studies. FDA approved Watchman back in March 2015, and these are the clear actual wording for the approval. So FDA approval for patients who are deemed by the physicians to be suitable for warfarin, and yet they have an appropriate rationale to seek non-pharmacologic alternative to Watchman. But in order to get Watchman to be paid for by Medicare, CMS coverage requires a chest VAS score of 3 or greater, and you need formal shared decision making with an independent, non-interventional physician, and patients have to be suitable for short-term warfarin, so they can take the 45 days of warfarin, but they can't tolerate long-term oral anticoagulation. So what happened since Watchman was approved? In the first 14 months after Watchman was approved, 3,800 patients underwent Watchman device implant, really rampant. And this was done by 380 physicians from 170 sites in the US. And fortunately, the complication in this very early experience was actually pretty low. Pericardial tamponade with 1%, and peri-device stroke rate and mortality rate each less than 0.1%, and device embolization 0.2%. So this is very much similar to the clinical trial, randomized trial data, which is reassuring that we can replicate this data from randomized trial into real world practice. And the volume has rapidly increased since approval. And so you can see exponentially. So currently more than 600 centers in the US are implanting Watchman, and over 50,000 has been implanted so far over the past 3.5 years or 4 years. Now the NCDR, so all patients have to be registered. NCDR LAO registry. The full data is not published yet, but last year at ACC they presented the nested cohort of 1,000 patients, and in that cohort of patients, the primary endpoint, which is looking at safety endpoint, met the performance goal, which again is reassuring. Now, what about data for outside of the US? Now, in the US, you can put this device in for patients who are eligible for OAC, as long as they can take 45 days, and ineligible patients. Outside of the US, majority of patients undergoing LAA closure are OAC contraindicated population because of funding issues, and also because of guidelines. So the evolution is the most best conducted prospective registry worldwide. About 1,000 patients primarily enrolled in Europe. And you can see 62% were considered ineligible for oral anticoagulation. And after Watchman implant, only 27% were treated with OAC. The majority, actually 60%, were treated with DAP therapy, aspirin and clopidogrel, after Watchman implantation. And the 2-year outcome was just published a few months ago by Lucas Boersma. And when you look at the observed incidence of ischemic stroke, there was basically 80% reduction compared to the expected rate based upon their CHADS-VASc score. There was also a reduction in major bleeding by about half when you look at their expected rate based upon their HAS-BLED score. And when you look at the cohort of patients who were treated with DAP post, which is about 600 patients, very similar reduction in terms of observed rate of stroke by about 80%. Likewise, bleeding is reduced by about half as well. So that's one of the largest series that included use of DAP. Now, what about the other device? The M-Platzer cardiac plug is the second device that's most widely implanted from an endovascular perspective worldwide. The second generation of ACP is called the Amulet, and in total, there's been more than 30,000 total of the ACP and Amulet that's been implanted worldwide. And this design is a little bit different. It's more of a lobe and disc design, but also done percutaneously via transeptal puncture. Now, the best evidence to date for the Amulet device so far is this prospective observational registry, primarily in Europe as well, 1,000 patients. 83% were OAC contraindicated, and as well, if you look at what they received post implant, only 19% were treated with OAC post. Majority, 54%, were treated with DAP therapy. Even a smaller proportion, 25%, were treated with a single antiplatelet therapy, and mostly with aspirin after an M-Platzer implant. And the outcomes were quite similar compared to Watchman. The implant success rate was 99%. The 2-year outcome in this registry was just presented at EuroPCR this year. And I'll just summarize it here by saying that when they look at the 2-year outcome of ischemic stroke, what they observed was a roughly 70% reduction in the ischemic stroke compared to the observed stroke rate. So that should be published very soon by David Smith and group. So what's the current recommendation for percutaneous LAA closure? It's also weak. Class 2B recommendation for patients with high risk of stroke and yet they have contraindication to long-term OAC. And again, it's the level of evidence B, non-randomized, because this recommendation did not include the PROTECT and PREVAIL patients, which were patients who were eligible for OAC. So there is a bit of disparity in terms of the types of patients being treated in the US versus being treated worldwide. So in the US, again, you have to be suited for short-term OAC, whereas internationally, you can be eligible for short-term OAC or have absolute contraindication. So you can be treated with just DAP or even single antiplatelet therapy post. So the CE mark labeling has also changed outside the US. So they actually allow the use of DAP therapy for at least 3 months, and you can even use NOAC after one of these device therapy implant. Very recently, it's actually just this week, the EHRA, EAPCI expert consensus statement was just published online in both Europace as well as Eurointervention. And we provided a little bit more guidance as to what types of patients can be treated with LAA closure. So especially patients with contraindications to OAC, if you have a CHAS-VASc score 2 or greater, and you can tolerate at least 2 to 4 weeks of a single antiplatelet agent, this therapy can be considered, especially outside the US. Other patients who may be considered for LAA closure includes those at elevated bleeding risk or high HES-BLED score, patients who failed OAC in the sense they have a stroke on top of OAC, or they have electrically isolated LAA, so post-ablation, because of the stroke risk is higher, they also can be considered for this therapy. And another recommendation from this document was what kind of antithrombotic therapy can be given. If you're eligible to receive short-term OAC, that will be the preferred therapy. But if you're contraindicated for any OAC post, then the recommendation is you can use DAP therapy for 1 to 6 months. And in patients whose bleeding risk is extraordinarily high, you might consider a single antiplatelet therapy if approved by a team consensus approach. So how do we do this procedure? So typically we start off with some sort of baseline imaging. Most centers would do TEE as a baseline, whereas we routinely do a CT as a baseline because we think that the anatomy that you can obtain from CT and a 3-dimensional relationship on CT is so much better compared to seeing on TEE. So we do CTs routinely, and it gives an idea about which device is suitable, because in Canada we can use both an amulet and Watchman, so we can choose according to anatomy. And also we get the sizing, which has been shown to be more accurate with CT, usually about 2 millimeters larger than 2D TEE measurements. So the typical way of doing this is a transeptal puncture from the femoral venous approach, and you can use RF needle like this, or we can use a standard BRK needle. And then we advance a sheath across to the left atrium using, this is a protract wire, or you can use stiff NPLATS wire, and this is a TEE guided procedure. And once you have the sheath across, you use the pigtail to navigate, and this is really key step to prevent perforation. And so this has really minimized the risk of perforation and tamponade over the years. So use the pigtail to guide your large sheath into position. You can see the shape here is very similar to what we saw on CT. And so on CT, we already predicted which is the best angle to do the implant. And the implant is really just a straightforward unsheathing of this device. So this is a 14 French sheath, and we generally want to unsheath it very slowly, so just to avoid the device from jumping backwards. And after we deploy this device here, we usually do a little contrast injection to show that we're in good position. I don't have TE images for this particular case to show, but that's very important to confirm on TE in 4 different views to make sure that we're well positioned. And here we're doing a tuck test to make sure that we're not able to pull this device out. Take another contrast injection to make sure that the device has not moved. Likewise, confirm it on TE, the device has not moved. And then to release the device by simply a counterclock rotation of the sheath itself, and that's the final picture. And so before we release the device, the company has certain guidelines as to when you can release. So you have to meet the PASS criteria. Position, you have to be distal to or at the ostium of the LAA. You need to check the anchor by doing the tuck test. The size, you need to be compressed by between 8 to 20% of the original size of the device. And seal, meaning you need to cover all the lobes, and there should not be any leak that is more than 5 millimeters. And then that's really key, because if your leak is more than 5 millimeters, then you would have to continue on oral anticoagulation long term. And after implants of these devices, you should perform device surveillance. And typically, you need at least 1 device surveillance between 6 to 12 weeks of either TEE or CT. But if you are at risk for forming device-related thrombus, then the recommendation is you probably should do a second delayed TEE or CT to look for clot. And so these surveillances look for period device leak that's more than 5 millimeters, and also device-related thrombus. So what are the future directions for LAA closure? I'm going to sort of address a few areas: new devices, new randomized trials, combined procedures. You mentioned the ablation study and periprocedural imaging with LAA closure, and also like the ever world now. And so let's go over some of these. So new devices, there are a lot of new devices that will be on the horizon soon. You can divide these into more single lobe devices or the lobe and disc devices. And I didn't put down the Gore because you can't find a picture of it, but Gore is also developing their own single lobe device as well. And so these are the various clinical studies. A lot of them are doing a one-to-one comparison, non-inferiority randomized comparison to Watchman, which is a default Gen 2.5 device currently. So the Watchman Flex is the next generation of Gen 2.5 that's currently available. So Watchman Flex, you can see the feet are involuted and the 2 rows of anchors. So the involuted feet allow the device to be pulled back into a ball configuration, which then you can deploy and redeploy and recapture safely, and very much like the ball concept of the MPLATS or plug device. And you can see the sizing for Watchman Flex ranges broader than the current Gen 2.5, so it covers up to 32 millimeters for appendage size. And the Pinnacle Flex device, a 400-patient single arm registry prospective study that completed enrollment in a few months. And so we should see data soon. So that was the Watchman Flex, and they allowed the use of a novel agent post instead of warfarin. So that will give us some evidence again for using NOAC post. The Amulet study, I mentioned the post-marketing registry early for 1,000 patients, but they also completed the Amulet IDE study. I'm not sure if you were center, but they randomized basically patients to Watchman versus the Amulet, one-to-one arm comparison, and they completed enrollment of 1,800 patients in March this year. So we should see results in next year, probably. WaveCrest is also currently having the ongoing WaveCrest 2 study, which is comparing Watchman versus WaveCrest in the one-to-one comparison, about 1,300 patients. Lambert device, they're planning the reduced one, which is again the non-inferiority comparison to Watchman. It's not yet been launched. And I would say in China, Lambert is either the first or the second device that's implanted. And even giving the Watchman people scared because it's a Chinese company. And there's a bunch of other devices that are more early in their developments at this time point. I don't have time to go over Lariat, but Lariat is an important device therapy that isolates the appendage as well. So the AMAZE studies essentially completed enrollment of 600 patients, and the endpoint is to look at, not stroke, but to look at freedom from AFib, combining Lariat with pulmonary vein ablation versus pulmonary vein ablation alone. And I've talked about AtriClip already. So this is another different type of procedure where you require epicardial closure as well as transeptal puncture. I want to spend a few minutes here on the major large randomized controlled trial for contraindicated population. So ACEP2 is one of the most important ones. This is one of the first ones to be launched. So this is sponsored by Boston Scientific. And 888 patients will be randomized. These are patients considered not suitable for oral anticoagulation. And they're randomized in a 2-to-1 fashion to Watchman versus control. And control essentially is aspirin alone. And the primary endpoint is the time to first occurrence of ischemic stroke or systemic embolization. And where are we now with this patient in this study? It's very slow in enrollment. So we're about 350 patients in. So we're almost halfway there. And this has taken us over 2 years to do this. So we're thinking hopefully in another 2 years, we should complete enrollment. And I'll go through some of the criteria later this evening about who are suitable for ACEP2. But essentially patients were contraindicated to OAC. Now, outside of the US as well, there are the stroke close and closure AF studies, large randomized trials targeting contraindicated population. Stroke close is including only patients with prior intracranial hemorrhage. And they're randomizing 750 patients to Amulet versus control. Control could be nothing or antiplatelet therapy or OAC. And in DH patients, they allow basically aspirin alone or DAP therapy post-Amulet. And Closure AF is a large 1,400 patient study comparing LA closure versus medical therapy, again for OAC contraindicated population, also slow in enrollment. Now, PROG 17 just got presented at ESC this year. And so Vivek Reddy and team are preparing the manuscript. So 415 patients were randomized to NOAC versus LA closure. LA closure can be with any device, and NOAC primarily consisted of apixaban in 95% of cases. And they essentially found non-inferiority in the endpoint, which consisted of a sort of a net clinical benefit. So stroke, systemic embolization, bleeding, cardiovascular death, or any peri-procedural or device-related complications. So they found non-inferiority with this small patient study. There's also a lot of interest from the large device companies from Boston and Abbott Vascular to also do a big study comparing their device versus NOAC as well, and a more definitive study. So we'll hear more about those studies soon. Now, there's a lot of interest in terms of combining LAA closure with other structural procedure, including TAVR and mitral clip and ablation. So TAVR, there's an ongoing randomized trial called a Watch TAVR that Samir Kapadia at Cleveland Clinic is the PI, randomizing patients to simultaneous TAVR and Watchman versus TAVR alone. And we know that in patients undergoing TAVR, AFib is, prevalent. Over a third of patients have AFib and with severe aortic stenosis. So this is an important population to look at. Ablation, there's a lot of small series that were published, but the key trial here is the option trial that Mario has alluded to, 1,600 patients at 130 sites worldwide. This will be utilizing, it's already started, is utilizing Watchman Flex device, and essentially patients undergoing sequential or concomitant ablation. They're randomized to LAA closure with Watchman Flex versus a control arm, which is OAC. And the 36-month endpoint will be looking at stroke, systemic embolization, and all-cause death. So this will be a very important trial. Now, what about peri-procedural imaging? I showed you some of the pre-CT imaging that is very helpful to select the device and your equipment, like what sheath to use, for instance, and where to do your temps of the puncture. Also, importantly, you can actually do 3D printing for more challenging anatomy. Not routinely that we would do this, but challenging anatomy, 3D printing could be useful. But we can actually also do computational modeling to look at this. Now you can predict using artificial intelligence now, where is the best place to implant a device? Is it proximal? Is it distal? Likewise for both devices, Amulet and Watchman, and you can predict, a prior device leak as well. So these are different approaches you can do, and there's a really nice software by Fields. They've done work with TAVR, and this just progressed to doing LAA closure. And also utilize T. I wanted to have this video playing, so I'm just go back here. There. That's weird. I have to go back there again. Let's do this again. Hold on. Okay. Do that. I was clicking too much. One click. There. Okay. So, so you can do CT post as well, and that's the thing. Patients hate doing TE pre and post procedure, right? So if you can replace those TE with CT pre and CT post and only use TE during the procedure, patients love you. So that's what we've been able to do. So we've been able to compare CT post with TE in over 100 patients and essentially show that CT is better than TE in terms of picking up peri-device leak. And not only that, but CT can pick up the cause of the leak. It can pick up incomplete endothelialization. And so that's what we call fabric leak. And you can look at, you can use different software. Materialize is amazing software. They can look at 3D very well and look at apposition of these devices. So that's imaging. So minimalist approach in a sense that what can we do to avoid GA-TEE? And there's a lot of interest now to replace procedural TEE with, say, ICE guidance. And so various publications have shown good technical success rate with ICE guidance with different devices. A meta-analysis was just published recently in JACE, and it included 5 studies, about 1,200 patients who had ICE guidance, and they were able to show that there was no significant difference in acute procedural success with ICE guidance versus TE guidance, and there was no difference in procedural time overall and floor time, and also no difference in complication, which is important. And because we know that room turnover with ICE guidance is way shorter than GA TE guided procedure as well. And there's also the potential to use micro TE probes where you don't need GA. So in this small series that was published in JACC Invention a few months ago, 50 patients undergoing LAA closure using micro TE, primarily placed through transorally, and patients were not given GA. They were given local anesthesia and given IV midazolam and fentanyl, and they obtained good image quality and the follow-up that they had did not show high incidence of peri-device leak with device-related thrombus. So the image quality was deemed to be acceptable in all these cases. And another approach nowadays is actually just doing fluoroguided. Forget imaging altogether. And I think you can do this in a very experienced center, especially if you have baseline CT and you really understand the anatomy. You can do the procedure fluoro alone. And Bernie Meyer is one of the big proponents of that, of course. And on top of that, what about same-day discharge of patients, right? So actually in our center now, about 31% of our patients are discharged same day, be it TE guided or ICE guided. They go home the same day. We had to select these patients. I know funding restrictions here, you have to keep patients overnight, but in Canada, we have a lot of restrictions for bed. So all our PCI patients are discharged same day, ASD, PFO discharged same day, and LAA closure, if they're a good prototype, they're discharged same day. TAVR, not yet, but that will be soon. So in summary, there's a clear clinical need for LAA closure, especially for patients not suited for OAC. And clearly LAA closure can be performed safely now with good technical success rate and with effective long-term results. We do need to do routine device surveillance to make sure that there's no device-related issues like clot or peri-device leak. And important randomized trials from the contraindicated population is really ongoing, and those results from these studies will then change the guidelines to hopefully, class 2A at a minimum, maybe class 1 for the contraindicated population. We hope to see those changes. And there's so many device versus device trials for new iteration of these devices that may be better in terms of lower device-related thrombus, etc. And the combination with TAVR ablation is very important. And all these new imaging and minimalist approach, I think, are really gaining traction. Thank you. Yes, well.
Terrific talk, and I appreciate that you come in and also highlighting the importance of CT. I have a couple questions here. One is in regards to when would you select amulet versus Watchman? Is that related to those kind of wide but short? And what happened to lariat?
Yes.
Pittsburgh tube peritonitis. Yeah. Is there still a place for it?
Yeah. Okay. So in terms of device choosing for us, I try to be fair. So I always say I'm going to do half and half. On the procedural day, I'm going to do half and half Watchman and a half amulet. And I try and pick on the anatomy because I have CT for almost all these patients. So I'm going to pick, for those patients where, gosh, they have these retroflex chicken wing, the tip of the appendage is pointing to the right, or, then I would say, well, and it's not very deep. Multiple lows or early bifurcation, and say, you know what, I'll just fit an amulet in place. Other appendages where it's more windsocky, or or they have trabeculations that might limit the stability of the amulet lobe, then I might just go for Watchman. So I would say that there is more anatomy that fits amulet than anatomies that fit Gen 2.5. Okay, but that's not necessarily the case for Gen Flex. All right. And so Gen Flex can accommodate shorter appendages. So that would not be an issue, I think, anymore. But having the CT ahead of time allows you to choose. Now, the question about lariat is, lariat was used a lot early on before Watchman was approved in the US, right? Because it was 510K approved, and you can do it and not give OAC post as well. But the thing is, it's a very complex procedure, right? You need to do an epicardial access, and you need to do a transeptal, you need to do a dry tap, which is a very tough skill for interventionalists to learn. EP guys, they're more used to doing that for their ablation, but for IC people, to do a dry tap is hard. And then also, they've seen a lot of effusion, like over 10% of cases, effusion tamponade and inflammation, pain. So they have to routinely use colchicine, and they started using micropuncture needles to minimize the risk of tamponade. And there's also, very recently, Andrew Natalia's group, they published looking at peri-device leak after lariat as well. Is not inconsequential. About a quarter would have peri-device leak. And those patients with peri-device, even if it's less than 3 millimeters, they're associated with higher incidence of stroke as well. So I think we really do need to wait for a MACE study results to be published and to know. But because of the complexity of the procedure, that's why people are not doing it. I mean, in Canada, we didn't even bother. Because why? Because we got 2 devices, and we have LifeTech coming on board. We have wave credits coming. So if all those endovascular procedures out there, we can close over 99.9% appendages. And those that we don't even attempt because we've done CT, it was a really, And those patients can be treated with thoracoscopic AtriClip, right? So there it's not really fitting that space for us in Canada. And until, you know, unless you're really looking at the pulmonary vein ablation and the AF reduction burden itself, I think it would have that benefit, but it hasn't really gained grounds. Yeah, Paul.
Jackie, that was a great presentation.
Thank you. Yeah.
So one of the ideal populations is some patients who think about are the AFib like patients who are contraindicated, the ones that are being treated elsewhere in the world. So why, can you tell us why is AFib having such a hard time?
Yeah.
It seems like, as you say, it's under treatment.
Yeah.
A lot of patients out there.
That's right. So the part of the reason here in the US is hard to enroll is because these patients are being treated off-label, right? So your relative, so AFib allows enrollment of absolute contraindicated patients and relative contraindicated patients. And so in the US, these relative contraindicated patients are all being treated. So it's almost like the PFO story, right? And that's a big issue with this device therapy is the first randomized trials were done wrong. We should have targeted the OAC contraindicated population first, right? That's low hanging fruit. We would have had those class 1 indication right off the bat, but they did not. The first randomized trials were for eligible patients. Now you're backtracking, and now you want to include contraindicated population when the OAC eligible patients are available, so it's very hard to enroll. So it's not just in the US, but even throughout Canada. I'm referred patients who are contraindicated for the procedure. They come to me saying, I want device. So now I'm going to tell them, I can put you in this study. You have a 2 chance of getting a device and 1 chance of not getting. I'm like, no, I want a device. That's what the patients tell me. I want a device, right? So that's the challenge. So everywhere in the world, we're having challenges. So each center, we're at first, we're telling other centers, you know, you should target 1 patient every 2 months. We'll be happy if you try and enroll 1 patient every 2 months. Now it's down to 0.2 patients every 2 months. That's the average. That's how hard it is. That's why we expanded from 100 sites with the intention to include up to 120 global sites. And the FDA mandated at least, I think, at least a third has to be North American sites, right? And so that we include a lot of German sites. The German, because funding is not a problem in Germany. And so it's easier to enroll patients in many centers. So if you look at the distribution of sites enrolling in AFib2 is primarily outside the US, you know. So it's a very challenging study, but again, very important study to do. Yeah.
I have a question.
Yeah.
Oh, go ahead.
Yeah, Scott.
I just wondered if you had a perspective on infection and how you could get out
Yeah.
in that instance.
Yeah. So I must say, I haven't heard of a report where you have to extract the device because of infection. So generally what we recommend is that we always give oral antibiotics before the procedures. We typically use, you know, NSAID or vancomycin prior to implant. And after implant, we would recommend oral antibiotic prophylaxis with dental procedures for 6 months. So we haven't seen, you know, actual infection of the device that he needs to have the device extracted.
Yeah, we're thinking about going minimally invasive at some point. Not quite there yet, but what my thinking is with Riot is, okay, how do we approach this? You know, so if you right now would have a recommendation about minimalist approach, how would you do this from an imaging standpoint? Let's say you had all the devices available, but
Yep.
right now just maybe focusing on Flex, which hopefully will then also to us available. So how would you do that? CT, TEE, and then, I mean, what kind of
Yeah.
imaging would you do?
Yeah, so I would definitely, if I'm doing minimal invasive, CT for sure. There's no question. We changed our practice where we routinely do CT because in the early experience, there are a few cases where you just, you know, T images weren't great. You put a patient on a table and then it's like, now I can't use either devices and I have to cancel the procedure. And it's horrible for the patient. Like, I have a failed procedure. Ever since we've done routine CT, touch wood, here's wood. Never had to take a patient or have a failed procedure because you can predict what size and what device, where you want to implant. And so that enables you to be able to do the minimally invasive with just ICE guidance. I would say that the ICE technology right now, we don't have the 3D probe yet. The depth of field is not great. So when you do ICE, we still have to get into the left atrium to get a better image of the appendage. You can't just put it in the right atrium. So it does need a bit more technical finesse to do that. And the image quality is not great. So you can't really image the whole 360 to look at peri-device leak. So your early experience should include the flex, we include TE first, and probably have TE and ICE for the first few cases, like maybe first 5 cases, and then after that you can go just CT pre and then ICE guided alone, and then do your CT imaging post as a follow-up. So that will be our suggestions. And when we're doing ICE guided cases, we're doing CT pre, ICE guided, and then CT post.
Do you think that overall the next device is a better device for ICE guided?
So I think we need to see the comparative data about peri-device leak. So if you look at a Gen 2.5, we see peri-device leak on TE in about 30% of cases. On CT is about 60% of the cases, and that's probably because it's not quite as flexible a device. And so with the flex, there's more struts to that, and so it's better conforming. So your peri-device leak might be lower, so it might be less critical to look 360. Although there are a lot of implanters doing ICE with Gen 2.5, and they're not, that concerned. So one of the key is oversize a little bit more. We know that when we see peri-device leak is typically related to undersizing a device. So if you oversize a bit more, there's a lower chance of seeing that periosteal leak. Yep. Last question. Yeah.
The type of patients received oral anticoagulant versus placebo 30 years ago. How much different atrial fibrillation patients and what now?
So say that again in terms of the difference between patient.
Right. The type of patients that were in the original trial.
Okay.
Were higher risk patients than what you can see now. Are patients like patients identified with COVID, and so that the rate, when you look at historical controls versus what you're seeing in the study,
right.
That's not. Could you comment on how, since we can't do randomized trials any longer, it wouldn't be considered to be ethical. How do we account for that? The rate is really changing. For example, that may explain why ischemic stroke prevail was not inferior compared with watching.
Yeah. Yeah. So when you look at a chest vest, whether historically patients in the old trial, in the original trials, whether the chest vest was higher or lower compared, and I think it was actually, I have to go back and look at it, but I think those chest vest scores actually perhaps lower compared to a lot of the registry, maybe not a randomized, but a lot of registries, the chest vest score on average is over 4.5. And so those are very high stroke risk patients to begin with. And we're not saying that there's not going to be randomized trials. There are these ongoing randomized trials, and that's what we really need to change the guidelines indications. It's just going to be very, very slow to get there, unfortunately. And the prevail data, I mean, that's, people go back and look at it and say, well, why are those ischemic stroke events still occurring after Watchman? And but we got to keep in mind too that a lot of these patients, LAA is only one source of stroke, right? And you have those other 10% of clot that can form in the left atrium that occurs. And also these patients, when they have high chest vast score, they have other etiology of stroke. They have carotid disease, they have aortic atheroma as a cause. So we can't eliminate all sources of stroke altogether. And so there will be an intrinsic advantage, I think, to NOAC or to orphan long-term, because they prevent all the other causes of stroke that LAA closure is not going to target. So I still think that in the long run, patients who are great candidates for OAC should be OAC treated as first line. There's no question about it. If you look at the aggregate randomized trial data, it's over 70,000 patients that are studied in all these 4 big randomized trials. But in Watchman, it's only 1,100 patients, right? And even with the other trials, might be 10,000 patients at the end of the day, but it's still very small numbers. So I think LAA closure will still be targeting patients who are, of some reason, form or fashion, relative or absolutely contraindicated for OAC. But even for that indication alone, we should be targeting over half of the population of patients with AFib who meets the criteria, right? But right now, the penetrance of this device therapy, I'll show you in a slide for this evening, is that in the US, the penetrance for Watchman is only about 2.4% of patients who are actually eligible and are contraindicated OAC, et cetera. And globally, internationally, we're only penetrating about 5% of patients who are potentially eligible for this therapy, which is why there's so many devices in the market. So
And again, thank you.
thank you so much. I couldn't cover all the complications, so this is a very good book to review the rest of the data.